Thank you everybody for coming. Apologies for the technical issues, but we'll jump right in. So, my name is Dr. Duncan McGregor, and I am one of the co-chairs for GLAD, which is the Association of LGBT Doctors and Dentists. So I'll be talking to you today about a little bit about LGBT healthcare and what that means in the current day for the NHS. So as every good presentation begins, I'll just give a brief aims, but first a couple of apologies. First apology is while I've done lots of presentations on this topic before, I've never done it via a medium like this. I've never done it digitally. So if it's not quite slick, then we'll just have to forgive me. The other apology is for the unashamed amount of rainbows that there will be all over these slides. I think I may have spent more time crawling through Google Images for rainbow backgrounds, but hopefully it's visually enticing for you all. So over the next 30 minutes, I will be, I'll tell you a little bit about myself and why I'm here, talking to you. I'll talk a little bit about a very, very brief overview of LGBTQ plus health inequalities. I will talk about what it's like to be LGBTQ plus in the NHS workforce, and that will be a little bit about my own personal experiences and some of the personal experiences of colleagues and friends, but also a little bit about the data that we have from surveys and studies. I'll talk a little bit about some ongoing work in this field and what's happening in the field of LGBT health, and I'll close up with a little bit about what you can do, and hopefully we'll leave a little bit of time for questions at the end. I've got my phone up next to me with the chat going, so if there's anything that pops up that's pertinent, I'll try and answer it then. Otherwise, I'll go back at the end of the chat and see if we can bring together a few, tie together a few strings. So. Firstly, who am I? So I've already introduced myself. I'm Duncan. I'm a junior doctor based in Manchester. Professionally, my interests are in critical care, but the reason why I'm here talking to you today is because I'm the co-chair for an organisation called GLAD, which is the Association of LGBTQ Doctors and Dentists. It is a historical name, so GLAD, we used to be the Gay Lesbian Association of Doctors and Dentists, but obviously as times have changed, we've become more inclusive. So that's where the name may be a little bit confusing. But I've worked for GLAD for a few years now. I consider myself to be a bit of an activist in the field of LGBT health. GLAD is the UK's only group for LGBTQ doctors, dentists, and medical and dental students. We have three major aims and objectives. We are activists, so we try and combat discrimination, particularly where it pertains to LGBT health, LGBT patients, but also the LGBT health workforce. We run a lot of networking, so social events, professional networking, and that may be networking around just the rest of medicine, or it may be pertaining to LGBT health specifically. And we do a lot of education around themes of LGBT health. The other thing that we do a lot of is we've got a lot of links with the BMA, who are the Doctors Union, the GMC, who are the Doctors Regulators. We work a lot with the Royal Colleges, who are involved with postgraduate training for doctors, and we have quite close ties with the National LGBT Advisor, that is the government's advisor for LGBT health, on the back of some recent very significant studies into the lives of LGBT people. So we have quite a lot of links, and we try and bring these interested bodies together to advance the state of health for LGBT people. So that's, as I say, the first part, just a little bit about who I am and why I'm here, why I'm qualified to give you this talk, essentially. The next section is, as I say, a very brief overview of LGBTQ health inequalities. So the first disclaimer on this is, I apologise, it's a fairly text-heavy series of slides. Generally, I prefer to ramble on more than let people sit and read slides, but there's areas of this where you just need the stats up on the screen. The other apology is that these data are a little bit outdated. So these come from a teaching session, a lecture that we have developed on LGBT health inequalities that are delivered to medical students. However, they're in need of a little bit of an update. So some of these, while the trends are likely similar, the exact figures might be slightly outdated. LGBT health inequalities has, over the last 5 to 10 years, really expanded and skyrocketed as an area of interest within the health service and within the wider political sphere. This is on the back of a really significant and wide-reaching study a few years ago, the LGBT survey by the government, with over 100,000 responses. And it was particularly damning about the state of health for LGBT people in this country. It was damning about other areas of life, but when it came to health, healthcare, it was not good. As current or future healthcare workers, it's really very important to have an appreciation and understanding of LGBT health inequalities. I'll be honest, a number of these statistics, even though I'm an activist in this area, I don't remember and I don't apply specific numbers to my day-to-day clinical practice. However, it is very important for people to have an appreciation. So, for example, we'll take that first statistic on the slide there. Lesbian or bisexual women being twice as likely to have never had a cervical smear. Now, what's important to understand with each of these health inequalities is why that might be the case and what are the implications of that inequality. So in this case, there are a number of potential explanations as to why lesbian and bisexual women are less likely to have a cervical smear. It may be because a lot of cervical smears are offered opportunistically in maternity or sexual health clinic environments. So there is a structural logistic problem as to why these women aren't being targeted less for this health intervention. It may be that there is an institutional bias or an institutional homophobia in that clinicians are less likely to offer these tests to lesbian or bisexual women because they think their risk is lower. And there may be other reasons that are unclear to us. So that's one thing. The latter part is around understanding the implications. So in this case, cervical smears are part of cancer detection for cervical cancer, are a key linchpin. And if you have a group of people who are who are more at risk of passing through the net, then you have a group of people who are more at risk of a very significant healthcare, a very significant condition. So that is a brief overview of why these health inequalities are important to consider. I'm not going to go through each and every one here, but it's important to think about why are these health inequalities important to consider, and what are the trends of these health inequalities. So the significant trends of health inequalities that you'll see over this slide and the coming slides are particularly around mental health, particularly around substance misuse, and there are some interesting unexpected physical healthcare risks. Around mental health, as you can see here, rates of self-harm are higher, rates of low mood, anxiety, rates of eating disorders are higher. Substance misuse, the really interesting thing about substance misuse, it is more prevalent in the LGBTQ community, but the trend of substance misuse by comparison to the rest of the population is even more interesting. In the general population, rates of substance misuse are declining, as they are in the LGBT population, but they're declining at a slower rate in the LGBT population. So the gap is widening. Now, why would that be? Are services not targeting the LGBT population? Is it linked with mental health and mental health services being inadequately equipped to help LGBT people? I'll be honest, I don't know, but it's very important for us to, as current or future healthcare workers, to appreciate that, so that we can be positively biased, so we can put safeguards in place for more at-risk groups. With regards to other, as I say, the other category, the unexpected physical health. So here we have the, as I was explaining earlier, about the cervical smears, or with regards to that statistic there about gay and bisexual men being less likely to discuss heart disease with the GP. I honestly have no explanation for that I can think of, but it's a really important statistic to be aware of. You may notice that I'm not highlighting really any statistics around sexually transmitted infections in gay and bisexual men, because that is the one area of LGBT health inequalities that has been done very well, and culture in gay and bisexual men is around STIs and sexual health has changed so rapidly in the last decade or so that they access clinics much more readily and frequently than their heterosexual counterparts. So I'm really not going to focus on that at all, because it's something that has been addressed and is being. There are specific clinics, and their sexual health clinics are much better equipped at helping gay and bisexual men. The next aspect is around interaction with healthcare, which is, I think, really important. So these statistics are all about negative experiences with healthcare. So LGBT populations generally report higher rates of negative experiences with healthcare and healthcare interactions. Many are not out to their general practitioners. many felt that inappropriate comments were made, which feeds into this negative experience. And one of the key things that we at GLAD think about when we're trying to improve the state of education and improve the state of healthcare for LGBT people is that people that go into healthcare are not bad people. They're not bigots. They're not intrinsically bad people. Generally, they're good people. You wouldn't go into work in the NHS if you were selfish and bigoted. There are the very small population of people that work in the NHS that have genuinely deep-rooted negative negative views about LGBT people. But the vast majority of these negative experiences, we believe, are rooted in ignorance, essentially, in people who are generally well-meaning but are simply ignorant. And the cure for ignorance, the antidote, is education. This is the whole premise of how we work towards improving the state of health inequalities. Is if you educate the workforce, you cure ignorance. You're not going to manage to target that small minority of people who have genuinely deep-seated, deep-rooted negative views. That's not where education comes in. But the vast majority of negative experiences, that is the purview of education. And an implication of that is that LGBT people who have negative experiences of healthcare are less likely to present to healthcare. They're less likely to engage with healthcare, and so those health inequalities, those healthcare outcomes are worse because they have a worse burden of disease because they present late. This slide is focused, as you can see, on trans individuals, and I've given iterations and variations of this lecture many times, and there are statistics on this slide that really send a chill down my spine even now, because it is frankly abominable. Statistics like 50% of trans people having attempted suicide. I've not put an exact number on the low mood, anxiety, depression, but it is abominably high. It is almost in certain areas almost 100%. It is in the high 90s. It is frankly mind-boggling how bad the state of health inequalities are within trans populations. Rates of domestic abuse are higher, and the implications on healthcare and mental health with regards to that. And as you can see, a really staggeringly high risk of having HIV. I'm going to move on now in the interests of timekeeping and making sure there's enough time for questions at the end, for a bit of a discussion about what it's like to be LGBT in the NHS. So firstly is the stats. So a few years ago, GLAD and the BMA, which is the Doctors Union, performed a joint survey on homophobia, the prevalence of homophobia and biphobia in the NHS. And a significant amount, the vast majority of respondents had experienced some kind of negative experience with regards to their sexual orientation. A much smaller number, but still significant, felt that there was presence of harassment or abuse relating to their sexual orientation. And a similar number felt that it went beyond harassment or abuse and it was discrimination. The really interesting statistic for me here is that a minority, a really significant minority, reported this in any way to anybody senior. That's a quarter of the 12% and a fifth of the 12%. So really small amounts of individuals felt that this was behaviour to report. You'll notice some of the eagle-eyed amongst you will notice that there's nothing in there around transphobia and trans individuals. So it wasn't within the scope of that original survey. However, we are in the process of undertaking similar work looking into the presence of transphobia in the NHS. So that's a watch this space area. My own individual experiences of being LGBT in the workplace in the NHS. So disclaimer, I am an openly gay man working in the NHS. Personally, I have only ever had one negative experience. That was early on in my medical school when a peer made a joke in extremely poor taste, which I challenged. But apart from that, I have only really had supportive and welcoming views and reactions to me being open and out in the NHS. I found the NHS generally to be very progressive, and I've had opportunities working with GLAD to do things that I wouldn't have been able to do otherwise. I have had opportunities to educate, to be an activist, to engage with regulators and unions. I know that colleagues of mine, friends, peers who have had varied experiences would not be happy about this slide in particular, and I'm not trying to say that that this is everybody's experience. But what I don't want you to do is that I don't want you to think the NHS is a horrible, awful place for LGBT people to work. And in all honesty, I don't have the stats, I don't have the figures to tell you why some people have good experiences and some people have bad experiences. We just don't have that data. But ultimately, it can be a bit of a mixed bag, unfortunately. But that's why I'm here doing the work I'm doing. So, work that is going on in this field, we have in the education sphere. So we're working to try and improve the state of undergraduate curricula with regards to LGBT health education. So previous surveys have found that the medical school curricula it's very spotty across the country. There are some areas of excellence and some areas of dreadful exposure to LGBT health topics. And what we want to try and do is encourage medical schools to incorporate more up-to-date and inclusive education. We're working with postgraduate training programs. So we have done work with, as I said, with some of the Royal Colleges to try and improve the state of postgraduate training and make sure that there are integrated topics of LGBT health. And allied healthcare practitioners. So this is an area that I to date haven't had huge amounts of experience with, because it is such a vast area of healthcare, but so wide-reaching with regards to patient interaction and patient care. And my understanding is that similar to medical education, nursing education and allied healthcare practitioners have very patchy, spotty, variable experience of education around LGBT healthcare topics. So trying to improve the state of education in all areas of healthcare is one of the main goals in the LGBT healthcare movement at the moment. With regards to activism, so one of the main points that you may or may not have seen recently is around conversion therapy. So there's been a lot of political impetus over the last couple of weeks about this. Conversion therapy is an abhorrent practice. It is has been shown to be damaging, traumatic, and at the very best ineffective for what they're trying to do with it. We're trying to, amongst many other organizations, trying to push government to enact a legal ban. The provision of gender identity services and gender identity clinics is, again, very patchy, and the wait times are extraordinarily long. And so work is going on from I must admit, it's far above my pay grade, but from a policymaker perspective, to try and improve the state of gender identity clinic accessibility. Supporting LGBTQ plus healthcare workers is a really key part. So as you may see at the top of the slide, and you might be able to see, I've got my badge on here. There's the NHS Rainbow Badge Scheme, which is all about visibility and trying to improve the state of visibility for LGBT people in the NHS. We're trying to support LGBT healthcare workers to feel, as I feel, like they can be out and comfortable in the workplace without fear of discrimination. And broadly improving the state of LGBT healthcare. So we've already talked a very brief overview of the state of LGBT health inequalities, and trying to target key areas where LGBT healthcare can be improved. So finally, before we go to some questions, I'm going to talk a little bit about what you can do as current or future healthcare practitioners to improve the state of things for LGBT patients, but also colleagues. So the key one, if there is one take-home message from this entire presentation, it is: do not make assumptions. Don't make assumptions. Don't make assumptions. Don't make assumptions. LGBT people are used to being asked questions about being LGBT. If you don't understand something, if it is something that is outside of your realms of experience, just ask sensitively. Be sensitive about it, but ask. The vast majority of LGBT people would prefer a sensitively asked question than an ignorant assumption. There are some other key things that you can do. Acknowledging partners. There's some really interesting academic work going on about how we can improve education around recognition of partners in healthcare, using gender neutral terms, simply asking patients who it is they have with them in a non-assumptive manner, because you never know whether that person next to them is a friend, a partner, a sibling, a parent, a daughter, and it can be quite damaging to that relationship if you make negative assumptions. The other key one that I want to highlight is about the words you use. So healthcare workers, because of the nature of healthcare being so close to our humanity, healthcare workers are seen by a lot of patients as on a pedestal. The words you use carry power to that patient. The words you use may stay with them for years, possibly even a lifetime. Think about the words you use and how that impacts the person in front of you. I'd like to highlight the concept of challenging colleagues' behaviour. It can be particularly difficult, especially as a junior, or if you're not directly in the team, it can be difficult to break that hierarchy and to challenge behaviour. If you don't feel comfortable challenging behaviour on the spot, I really encourage you to address it in one way or another, and most NHS organisations have some mechanism or other to escalate gripes and concerns around behaviour like this. So please don't sit on bad behaviour. Finally, when it comes to trans patients, the state of things can be ever so slightly different. Pronouns and use of titles are really, really important. And again, I refer to don't make assumptions. Asking sensitively what pronouns a trans patient or colleague prefers, how they would like to be referred to, is, if you're uncertain, is simply the best way. And there can sometimes be, when it comes to healthcare, potentially difficult issues around asking invasive questions for trans people. The important thing is that if you have to ask invasive questions about a trans person's body, highlight why you need to ask that, because a big issue for trans people who have negative experiences of healthcare is a feeling of invasive questions being asked out of curiosity, not out of need. So that's a really key thing to do. I'm going to stop the presentation there and open up. There's been lots of questions and comments popping through, so I'll go through some of that. There's some extra information here that you can access. There's some really, really useful information out there. I'd highlight the Royal College of General Practitioners. They have the LGBT Hub, which is open with some really useful information for around on topics of LGBT healthcare. I probably shouldn't, given that I should be plugging my own website, I shouldn't have put it quite so tinily right at the bottom, but you can see there our website, glad.co.uk. You can access, if you're a medical student, dental student, or a current doctor or dentist, then please do look us up on our website, on Twitter, which is @GladUK. Please get in contact with us if any of what I have been talking about has been of interest to you. So what I'm going to do is just try and come out of this now, and I will stop sharing, and let's have a look at some of the questions coming through. So we have, after the issues with the getting started, we have a question around, do you think the NHS is set up as a binary system and so is letting down non-binary folk? So this is a really interesting question. Yes, I think a lot of the way the NHS is run, it's is very much about binary and man, woman, male, female, and it's very difficult for the behemoth of an institution of the NHS to step outside of labels and boxes. And this is a really key issue around gender, and the conversation, the ongoing conversation around gender at the moment is this generation is one that is increasingly rejecting boxes and binaries, and increasingly accepting self-description. And the NHS isn't isn't set up to work like that. The other issue on this is around healthcare workers. So some really big work that we've been part of recently is working with the GMC, which is the doctors regulator, to look at, there's a public medical register. You can search me and any other doctor on there as a member of the public, and the only piece up until, well, it's still currently the only piece of information that is on the list of protected characteristics is gender. You have man or woman. And what we have worked with the GMC to do is to allow doctors to have that removed. So you can now, for the first time, be on the GMC register without a gender. The problem is you can't have a non-binary gender on there. So it's either man, woman, or no gender on there. So there's lots of little things like that that are an issue for non-binary people. But thank you for that question. What are the benefits to being out to your GP? So thanks for that question. There was some of you who are in healthcare or who are particularly eagle-eyed on this topic will have seen not too long ago, I think it was last year, there was a big issue around GPs now being required to ask patients their sexuality. In the same way that you have your address, your date of birth, your name, your ethnicity on there, it's now required that GPs ask for your sexuality, and they can say no. You can say prefer not to say. But given all of the healthcare inequalities that exist for LGBT patients, I personally think it's really important, A, for the individual clinician to know if you are LGBT, there are certain risk factors, as explained earlier. But B, it's really interesting. It's not interesting, really important to have data, because unless there's a really good quote, and I'm probably going to absolutely butcher it, but unless you are counted, you do not count. So until we have good data on how many LGBT people are out there and what they're going to their GP, why they're going to hospital, what conditions they have, then we can never address healthcare inequalities. We have to have the data before we can say we need to improve things. I understand that there are plenty of people from my community, so Muslim and South Asian, from the LGBT community, rudely and unjustly in the past and current. I'm a big advocate for LGBT rights and the best ally. Do you have any tips and advice on how to be the best ally possible, especially in the healthcare field? So thank you for that question. The question essentially is, how can you be the best ally to the LGBT people? And I think especially from a group of people that sometimes is highlighted as not being allies. So like I was saying at the end of the towards the end of the session, how you can help, I think you just need to support, you need to challenge. So there's this concept of allyship in lots of areas of civil rights, the civil rights movement at the moment. The he for she, a lot of white people standing up for Black Lives Matter, and it's about, I think a lot of this is about using your privilege to support people. So as a non-LGBT person, you may feel more comfortable to challenge homophobia than somebody who is on the receiving end of it. If you are working in an environment where somebody is clearly uncomfortable, you know, stand up and support them and challenge that behavior. And just generally educate and help educate others. Do you have any info or stats on trans people's experiences in healthcare? So I would highlight the results of the LGBT survey that the government produced a few years ago. There are some really interesting statistics. I don't have them to hand, but they are particularly damning, especially around experiences of healthcare in mental health for trans people. Is this discrimination also coming from patients, especially for trans people? So I think one of the things and one of the reasons why we have the rainbow badge scheme is because being LGBT can often be an invisible characteristic. And you know, for me, I've never experienced anything from my patients because I'm not out to my patients. A lot of people will experience because they are more visibly, they may have characteristics. So they may be particularly camp men, or as you've highlighted, trans people may be targetable by people, colleagues or patients. And thankfully, the NHS generally has a low threshold of tolerance for abuse for staff. But yes, it does happen, unfortunately. And most people who have worked in the NHS in one field or another have experienced abuse for something from their patients, and it's unfortunate, but we have to rely on each other, on the support from our colleagues to overcome that. How would you respond to a patient making homophobic comments? So this is interesting. There was a really good, one of my colleagues wrote a really good letter to this about this in, I think it was the I paper. I'll see if I can find it after I finish, and I'll post it here. But you have to consider, often patients come in extremis. They may be confused, they may be scared. So first, apply empathy. Appreciate that this may not be them being horrible or awful. If that continues and you think that they are being horrible and awful, I think you just have to challenge and say, that's not acceptable. I'm treating you as a healthcare practitioner, and I will not stand for abuse, and accept that there is this low threshold of abuse in the NHS. Are we approaching the end of the session?
Yes,
here?
We are, unfortunately, Dr. McGregor. Thank you so much for staying with us so far. I think we might have questions we might have enough time for a couple of minutes for a quick wrap up, if that's okay.
Yeah, so I'll just kind of a quick summary. So the state of LGBT healthcare in this country has been shown recently to be fairly damning. There are many healthcare inequalities that exist for LGBT people. It is a very exciting field. There's lots of political and healthcare organizational impetus to improve the state of things, but the key message is education, and education will always be the antidote to ignorance. If anybody has any further questions, please do feel free to contact me. I'll put my Twitter handle in the chat at the end, and that of GLAD. Please look us up and engage with us. It's been a pleasure. It's been an absolute pleasure to talk to you today. and I hope that something I've said has been helpful and will help you take forward to your practice more inclusive and accepting practice. Thank you very much.